Hello, my name is Dr. Mohammed Nashawi, and I'll be presenting a case of mucormycosis to the ACP National Conference. My poster is titled More Than Meets the Eye, Rhino-Orbital Cerebral Mucormycosis with Diabetic Ketoacidosis, presenting as periorbital edema resulting in evisceration and maxillectomy. Now, mucormycosis is characterized by an invasive fungal infection with the propensity to cause acute clinical decompensation and death. In some reports of the literature, case fatality rates hover around 50%. However, differential clinical courses and anatomical incursion, as in where the fungus seeds, leads to differential outcomes as well. Rhino-orbital cerebral mucormycosis, or ROCM, is a rapidly hostile variant that tends to exhibit poor outcomes, and this warrants prompt recognition, workup, and intervention, especially in the critical care setting. It is seldom included in differential diagnoses in those with head and neck pathology in the inpatient setting, as, just by sheer nature of parsimony and prevalence, this type of entity lends itself to often be overlooked. However, the acuity and risk factors involved in the consideration of mucormycosis may serve prudent during this assessment, especially in patients who have risk factors of hyperglycemia or immunodeficiency, as this type of disease can progress and lead to very critical morbidity and mortality. So when performing examinations on patients who have this type of comorbidity burden, it is important to be mindful of things such as craniofacial lesions and alertness to the degree of clinical deterioration. To illustrate such an example, we present the case of a 59-year-old Hispanic female with a past medical history significant for type 2 diabetes and hypertension. She initially presented to the emergency room complaining of altered mentation, global weakness, and toothache, generally nonspecific symptoms. The onset of these symptoms lasted for 4 days, and per family, she noted the use of amoxicillin without a valid prescription obtained from a foreign source. Progression of her symptoms with increased sinus pain and facial swelling prompted the family to seek emergent medical counsel. Upon admission to the emergency room, it was noted that she was markedly hyperglycemic, with an A1C of about 14% and a point of care glucose of 1,086 milligrams per deciliter. She also seemed to exhibit signs of acute kidney injury, as noted by a serum creatinine of 2.63 over the 1.5 times or 0.3 milligram per deciliter reference that KDIGO typically uses as a marker of acute kidney injury. Moreover, she had an elevated point of care lactate of 3.6 millimoles and a leukocytosis of 19.7 thousand units per microliter in the absence of something such as corticosteroids, in which we may tend to observe things like leukocyte demargination. She had a markedly elevated anion gap, and the aggregate of these symptoms seems to have suggested diabetic ketoacidosis. This warranted ICU admission, as these patients can critically decompensate. However, upon repletion with aggressive fluids, electrolytes, and insulin, the patient's clinical status failed to improve, at least from an encephalopathic perspective. This caused future concern into other forms of encephalopathy. Now, cues into diagnosing infection, such as rhino-orbital cerebral mucormycosis, are amenable to scrutiny of the orbit, such as violaceous hues, periorbital edema, and asymmetry relative to the unaffected eye. However, these differential diagnoses can be quite expansive and include, but not limited to, ecchymosis secondary to blunt trauma, which the patient endorsed having a history of falls, or orbital fracture secondary to fall, orbital cellulitis, preseptal cellulitis, or even sinonasal neoplasm are among other conditions which may mimic this type of feature. Now, generally, the monitoring of infections and acquired trauma or pre-existing deformities in the ICU is more amenable given the specialized and comprehensive care teams, the replete resources, and aggressive patient surveillance. So this leads to the possibility of frequent modulations or perturbations in assessing things such as ventilator response, response to antibiotics, or hemodynamic instability. Nevertheless, there are some studies that show that ophthalmic conditions in the ICU are commonly observed. However, there is a paucity of eye care as reported in the literature, which cites a predilection for the ICUs to focus on things such as management of solid organ failures. Lamentably, this results in a decrease with regards to the rigor and credence given to bedside examinations, including that of the eye specifically. In this case, I'd like to highlight the importance of noticing how important a good history and bedside clinical exam is. This patient stated that she had had a tooth removed from a foreign country, and it was initially suspected that there may have been some component of localized orthodontic infection. However, upon further review, it seemed like the mechanism of fall was not consistent with her bruising pattern in her violaceous eye. Moreover, the workup that revealed the profound nature of type 2 diabetes made it almost mandatory that a rhinal infectious agent was the cause, or at least should have been looked into, as the risks involved in missing such a diagnosis would be very severe. Now, as her mentation seemed to have gotten worse, we decided to acquire a CT head without contrast of the patient, as we can see in Figure 1 in our Results tab. Image A represents a coronal and sagittal reconstruction of her cranium, and we can see that the intersection of each cross-section formed from the latter two views by the yellow X represents the maxillary sinus. And note the blue box located right above the maxillary sinus and the ethmoid cells. These exhibit hyperattenuation, which are consistent with an inflammatory condition. The red circle in the frontal sinus as a landmark helps also guide this phenomenon. Image B is the CT head section representing the depth of the maxillary sinus, demonstrated in image A with a contralateral sinus comparison. And note that the blue arrows show the air fluid levels in image B with opacification of the cavity consistent with sinusitis. Now, Figures 2 is more interesting in nature, as it shows a CT maxillofacial with contrast. The image on the right represents coronal multiplanar reformation of the head, and we can see that the elliptical area, as assessed by the left and right facial sides, shows that there's an increased soft tissue swelling of the left side greater than the right, marked by a biplane area measurement, about 19 centimeters relative to 15 centimeters as well. Moreover, the lack of attenuation difference gives credence for the lack of edema for radiographic impression. The purple ellipse outlined in the second image shows the ethmoid sinus being involved. Note the lack of medial structural integrity of the bone with the orbit and hypoattenuation of the lateral orbital bone, which also favors an invasive pathology. The yellow arrows demonstrate orbital fat pad processes, which are very common in fungal infections. Regarding the left image, the orange line shows orbital tenting, which is a common feature in invasive fungal infections. And the green line demonstrates extension and stretching of the orbital attachments of the left orbit relative to the right, again showing a mass effect of an infiltrative pathology. As is in this case, we would like to demonstrate that changes in the eye externally may indicate a wide array of pathologies, such as cellulitis, involving the eye being one of the more common differential diagnoses in ill patients with leukocytosis and hyperglycemia. Preseptal cellulitis and orbital cellulitis present with edema as well in leukocytic patients. However, after acquiring cultures and showing that there was presence of zygomycosis, head and neck surgery was consulted, and a maxillectomy as well as evisceration of the eye was warranted. In the conclusion, I would like to show that the endoscopic images did indeed show a ball of fungus consistent with mucormycosis, and the histopathological slide around the central white rim, which represents a blood vessel, shows migration of cells and gives a degree of the angioinvasive nature of mucormycosis. As internists, typically we see many patients who exhibit sequelae of type 2 diabetes, such as diabetic ketoacidosis and hyperosmolar osmotic syndrome. And it's very customary for us to follow our institutional protocols and undergo an aggressive regimen of volume resuscitation, electrolyte repletion, and insulin administration. But I want to outline this case to show that a concomitant bedside examination is very critical, as a lack thereof can result in a very fatal miss. Thank you for listening to this